The term genetic risk assessment can be confusing in our industry. There are an abundant number of companies that sell genetic-based tests to assess the risk of cancer. The majority of these companies are looking for a particular variant or a mutation in a gene. Most people are aware of BRCA mutations, for example. Mutations in BRCA can lead to increased hereditary breast and ovarian cancer risk. We are not one of those companies. The fact is, the majority of women are not at risk for carrying a mutation like this. Less than 0.2% of women actually have one of these hereditary mutations. But every woman has genomic risk factors associated with sporadic breast cancer risk. Think of this genomic risk factor like a little fingerprint indicating your risk of disease. The majority of these markers that we look at have no known functional mechanism. They will never change, but there is a pattern that we have identified that is associated with a higher risk of cancer. This is what we call polygenic risk, but we don't just look at polygenic risk because cancer is a multifactorial disease. It takes an accumulation of risk factors to eventually tip the scale towards cancer development. So for our risk assessment models, we combine polygenic risk with the most significant clinical risk factors associated with the disease. Having this objective, undeniable risk factor strengthens our discriminatory capability when it comes to predicting and personalizing a person's chance of developing disease. The number one risk factor for cancer is age. As we get older, our risk of developing cancer continues to increase. Then you start layering on additional risks, those you can't control, like your family history of cancer, and those you can control, like your alcohol intake. In the end, numerous potential risk factors can make for a treacherous questionnaire and a complex algorithm. GeneType streamlines this process. We look at a handful of clinical risk factors in combination with polygenic risk. One of our primary goals in developing our product line was to limit the number of incorporated risk factors to only the most impactful. There are many, many risk factors that a patient and a clinician could discuss, but we were particularly mindful of the limited amount of time during a wellness visit. When it comes down to it, a lot of clinicians simply don't have the time to provide risk assessments for every disease, and they have to pick and choose what may be best for their patient. Our goal is to enable clinicians to provide thorough risk assessment options by simplifying the questionnaire process so the clinician can actually focus on the subsequent screening and prevention options for their patients. Ultimately, all of our GeneType products are designed to directly compete with clinical gold standard risk assessment models. But based on our proprietary algorithms, they incorporate the least number of risk factors possible while still maintaining a high degree of discriminatory power. For our flagship product, GeneType for breast cancer, we look at a woman's age, family history, breast density, BMI, menopausal status, and polygenic risk score. We report the woman's risk of developing breast cancer over a period of time. There are certain established clinical guidelines that indicate actionable risk score thresholds, at which point a woman is considered high risk and is offered risk-reducing medications or supplemental screening options. If a woman has a risk factor that is not incorporated into GeneType, GeneType can still provide valuable information on her baseline absolute risk score. But when the results are returned, it is important for the clinician to keep in mind the impact of the additional risk factor and what it may have on the patient's overall risk score. An example of this can be as simple as parity status. A woman that has never given birth is at a slightly increased risk of breast cancer. This additional risk factor will have a slightly insignificant effect on the absolute risk score provided by GeneType, but it is still important and worth discussing between the patient and clinician. A more dramatic example of this could be a woman with benign breast disease. GeneType does not incorporate benign breast disease into our risk model, yet the impact of this can have a significant impact on the overall risk score. In these circumstances, the GeneType risk score may still provide beneficial information regarding a patient's risk, but our absolute risk score should be supplemental to biopsy risk status when it comes down to the patient-clinician decision-making process. GeneType results are delivered in a simple report format that indicates the patient's absolute risk score over 2 periods of time, over 5 years and over her remaining lifetime. Medical bodies have established actionable risk thresholds for both of these periods. The GeneType test will clearly indicate if a woman surpasses the established clinical risk thresholds. The American Society of Clinical Oncology and the National Comprehensive Cancer Network both use 1.67% for their threshold for 5-year risk. That translates to a roughly 1 in 60 chance of developing breast cancer over the next 5 years. The U.S. Preventative Services Task Force use a more conservative approach with a 3% threshold, or a 1 in 33% chance of developing breast cancer over a 5-year period. A lifetime risk score above 20% is considered high risk by the National Comprehensive Cancer Network and the American Cancer Society. This translates to a 1 in 5 chance or greater of developing breast cancer over an entire lifetime. To put this 20% threshold into perspective, the average woman has a 12% chance of developing breast cancer over her lifetime. If a woman is identified as at increased risk for breast cancer, she may qualify for additional surveillance or risk-reducing medication options based on the clinically established actionable threshold. Some clinicians are comfortable managing their high-risk patients, and others are more comfortable referring them to high-risk clinics for follow-up. It is important to remember that a GeneType test is a risk prediction test, and it's only able to estimate the patient's chance of developing disease. Just as a high-risk patient may never develop breast cancer, an average-risk patient is still at risk of developing disease. GeneType is not a replacement for traditional screening mechanisms like mammography, but it is a tool to better identify patients that would benefit from additional screening and preventive options. Ultimately, GeneType can help bring awareness of breast cancer risk and can aid and inspire discussion around proactive preventative healthcare options.